Hello everybody, I'm Dan Cummings and welcome to this special hour-long edition of Newsmakers. We are streaming it live for you on localsyr.com here on Thursday afternoon, March 26th. We will also be broadcasting it for you at 7 o'clock Thursday evening. Maybe you're watching it that evening, this evening, Thursday or Saturday morning. But I want you to bear in mind we are having this conversation at this hour. Things change by the hour with this program. But we're giving this program as much wide exposure as we can so that we can all learn what we need to know about COVID-19, the coronavirus pandemic, which has sickened many, killed many, and is still spreading. For most of us, 80% of the entire population, we're told if we do get it, COVID-19, we won't be that sick, or maybe not sick at all, but we can carry it and we can spread it to others. So let's meet our expert guests now who will help us learn a lot over the next hour. We welcome on the right-hand side of your screen Dr. Stephen Thomas, Director of the Infectious Disease Division at Upstate University Hospital in Syracuse. And on the left of your screen is the hospital CEO, Dr. Robert Corona. Welcome you both to the program.
Thanks,
really
man.
Grateful for your time. You guys are busy trying to stem this thing, and you've given so much of your time to us and to others in the media who are trying to help everybody else understand it, so we thank you. Before we get into details, Dr. Corona, that is your given name, right? The height of irony, just I could not let that go. Yeah. It's good to have you here.
Thank
and I'm
you.
sure I'm not the first one that's mentioned it. And Dr. Thomas, when you first went to medical school at Albany, right?
I did.
You chose a specialty. Was this your first choice for a specialty, infectious disease?
It was not.
What was your first choice?
I thought I wanted to be an oncologist.
Do you ever regret that choice?
No, I do not.
You never, though, I imagine, when you chose this specialty and trained for infectious diseases, that you would ever, or did you? You game planned for this, but did you ever really think you would face what we're facing now?
Not at this magnitude, not at this scale. The expectation was because of what we saw with Ebola, what we had with chikungunya, Zika, MERS. I thought we would just see kind of disruptive but regional epidemics, not a pandemic where 196 countries on the planet have SARS-CoV-2 transmission and COVID disease. I never anticipated the scope.
And yet here we are. So let's talk about some of the basics, and then we'll move on to the healthcare system and how we are and can respond going forward. Doctor, what is the coronavirus? Where did it originate? Why is it spreading so fast?
So the coronaviruses, there are about 7 that we think infect humans. 4 of them we call community-acquired coronaviruses because they cause about 10 to 30% of the common cold every fall and winter. They're global, and most of the time it's just a mild upper respiratory tract infection. And then there are 3 that can cause severe disease. So in 2002 we saw SARS, which some are calling SARS-CoV-1 because it was the first, so severe acute respiratory syndrome. And then the second, which was around 2012, was MERS-CoV, so Middle Eastern Respiratory Syndrome, CoV. And then obviously 10 years after that, we're now with SARS-CoV-2, which is the virus that causes COVID-19. So we believe that much like SARS-CoV-1 and MERS-CoV, that it was a virus that was found in bats. And then that virus jumped to other animal species, and those animals came in contact with humans, and then those humans got infected. One of the common examples that is talked about is, in many places in Asia, they have these markets where they have they sell animals basically, and so you have animals that get infected. The animals are stacked on one another. They have infected material dripping from animal to animal, and then the people handle those animals. They get infected. And if it can be passed from person to person, then that's where you see outbreaks like this. So this started in Wuhan, China, at a market in Wuhan, China, and then spread from there. One of the things that's very concerning about SARS-CoV-2 is it seems to be more transmittable than influenza. So we talk about these things called reproductive numbers. So that's the number of people that an infected person could infect. So for influenza, we think it's about 1.2 to 1.5, whereas for SARS-CoV-2, we think it's more like 2 to 3 people. So one person can infect 3 people. Each of those people can then infect 3 people, and so on. And so you can see how the numbers could rise dramatically.
Anyone of any age can be infected, right?
Absolutely.
Yeah. And it's transmitted by what method?
So we think primarily it's treated through respiratory droplets. So it's a respiratory infection, and so you can have, if you sneeze, If you cough, then you can have these respiratory droplets that have virus in them. And if you're standing within 6 feet of a person for a sustained period of time, anywhere but 10 to 15 minutes, and they sneeze or they cough, you could potentially breathe it in. The other thing that could happen is, those viruses are up in the air and then they come down due to gravity onto surfaces. And so if there's somebody who's infected in an area and they cough or they sneeze and they get virus on a surface, it's possible that you can touch that surface, pick up a virus. If you touch your eye, your nose, or your mouth, then you could infect yourself in that way, which is why we are so diligent about telling people to practice good respiratory hygiene. So cough in your sleeve, wash your hands, cough into a tissue, throw it out, wash your hands. And if you're not sick, make sure to wash your hands all the time. So that's why we give that guidance.
All right, we have a lot more to talk about with both Dr. Thomas and Dr. Corona when we come back on this special edition of Newsmakers. Don't go away. We'll see you in a minute and a half. Back on this special edition of Newsmakers on this Thursday with the coronavirus. It's already killed more than 1,000 people nationally, sickened many, and this is far from over. We're talking today with the director of the Infectious Disease Division at Upstate University Hospital, Dr. Stephen Thomas, and the CEO of Upstate, Dr. Robert Corona. Dr. Thomas, the symptoms that we should look out for. How do we know that we're ill? First of all, if we are symptomatic, what would those symptoms be?
Right. So that's something that there's new information coming in all the time. So it's not a completely written story yet. But we think there's kind of two phases to this. So the first phase can be very nonspecific. So people may or may not have fever, but they're going to have a general sense of not feeling well. They may have profound fatigue. They might have generalized muscle aches. And they may or may not have cough at that point in time. And then if they're going to transition to the more severe form of the disease, they will develop fever, they will develop cough, they might have shortness of breath associated with that, and then those other symptoms of fatigue and muscle aches will continue. About 80% of people are going to have a mild form of disease and they're going to do fine. About 20% though are going to have severe disease. They're probably going to need to be admitted to the hospital. And in about 5% of people, they're going to develop a critical illness, which their organs may fail or they may need to end up, be put on a ventilator.
And we've seen some of those pictures as you've been talking. Dr. Corona, at Upstate University Hospital and in the central New York region as a whole, since I know you work as a hospital counsel, do we have enough beds and do we have enough ventilators to serve those most critically ill that Dr. Thomas referred to, those who need intensive care?
Well, it's a day-by-day operation, and right now we do. But we worry about the surge and the peak and whether or not we'll have adequate numbers. We do serve more than just the Onondaga County area. We serve a pretty vast region all the way up to the Canadian border, down to the Pennsylvania border. So we look at this twice a day. We look at the numbers in our incident command team with Dr. Thomas has been leading. And we anticipate we may be at our limits and are looking at different options, like putting 2 patients on 1 ventilator as an option, like Governor Cuomo talked about.
And that apparently has been approved and works, right? When you take 1 and split it for 2 patients? That's what the governor said today at the briefing.
Yeah, I think it works, although it's not something that we would usually do. Right now, I think we're testing a lot of it. It's not optimal, but we're making do with what we have.
You mentioned a moment ago we are at our peak. Are we at capacity and about to exceed it, or do you anticipate that we will?
We're not at capacity right now. Yeah. And in fact, we were asked by the governor, all the CEOs of all the hospitals in the state, to provide a surge capacity program, and Upstate was asked to increase their capacity by 50% like the rest of the hospitals. We were able to give a proposal of a 77% increase in capacity by repurposing rooms, repurposing post-op rooms, maybe our operating rooms as ICUs. We're looking at a number of different options.
All within existing facilities?
All within existing facilities.
So you wouldn't have to go to any other pieces of real estate to put those 77% extra beds in the
Not with this present proposal.
To your knowledge, are the other hospitals able to do something similar? I don't want you to speak for the other hospitals, but you're probably on the planning council. Are the others, St. Joe's, the rest of them, are they able to also up their beds?
Yes. Everybody has at least made a proposal of 50% increase of capacity.
All right, so we're ready for that surge. What about the ventilators? If you have a lot of intensive care patients here, will there be the ventilators to serve them?
We don't know. Right now, we're hoping for the best, but it's day to day.
Yeah. Dr. Thomas, the respiratory nature of this disease we've seen, and we've just talked about some of the scariest end game if you're that ill. Who is most at risk from being that sick, to needing intensive care and a ventilator, and being very ill to the point of death?
Right, so in general, it's older people, so it's people over 55, 60 years of age. It's people with pre-existing medical problems, so cardiovascular disease, lung disease, like COPD, for example, people with diabetes. Young people can still become ill, and young people who have other pre-existing medical problems can also become very ill and not do well with this disease. If you look at case fatality rates, those increase as the age group increases. So most of the mortality that has been seen thus far has been in some of the older age groups.
But back to the 80% that might get a very mild illness or none at all, it is possible, is it, to have this virus within you and not even know it? You're a carrier, but you might never even have a single sniffle. Is that true?
Sure, and that's true for a lot of infectious diseases, that you can be infected and be what we call asymptomatic. So we would have expected that, this being a viral disease, that would be the case. The concerning thing to many people is whether or not those infected asymptomatic people can also be infectious and can also infect other people.
What's the answer to that?
I think the answer is yes.
That's why we're so concerned about
Yes.
social isolation and distancing one from another, right?
Exactly.
The community spread that we're trying to tamp down and avoid. So how many of us over the course of the outbreak might end up getting it, whether we get sick or not? I've heard ranges from 40 to 80% of the entire population might actually get this at some point, or already have it.
It's possible.
Yeah, that many.
It could be that high. It could be that high.
Let's talk about testing then, because there's been a lot of questions about testing. Dr. Corona, I'll start with you. If I have symptoms, because obviously if I'm not symptomatic, I'm not going to go get tested, but if I feel ill, and I think I might have the coronavirus, or I sure want to find out if I do, what do I do?
Well, there's an easy way to go through an assessment. We created what's called a chat bot, and it was done in collaboration with Microsoft. Now, they're doing it for a lot of institutions around the country, but they did a personalized one for the region, and so you can go online and run through a series of questions. The other thing you can do is go to your primary care doctor. Our family physicians and a lot of the frontline physicians have really stepped up, and they can run through a series of questions and potentially do a physical exam and make a determination, because as Dr. Thomas mentioned, there's so many upper respiratory infections that all look the same. In fact, you know, my granddaughter yesterday had a fever and a little bit of a cough, and of course parents were concerned, but ended up having croup. Now, normally we wouldn't be that concerned about a child having croup. So the frontline physicians, the family physicians can help. Once they decide that it's appropriate to have a test, they can do the test in their office and send it out to one of the national laboratories.
Your doctor can do that.
Your doctor can do that.
Any doctor's office, most likely. If my doctor says, gee, those symptoms sound like you got something there, Dan, I can go to his office or wherever he tells me to go and get a test?
That's correct.
All right.
Then there's a drive-through at the Syracuse Community Health Center
We've
where
been
a
seeing
lot
some
of
pictures
a
of
lot
that and other drive-throughs in the region as well.
And then at our hospital, we have a laboratory that can do the testing. Now, the exciting thing is some of the new testing that is coming through is more rapid. And there's even some hope about having point-of-care testing where somebody might have a handheld test, like a company, Abbott, makes a handheld test called iStat. And that's kind of the hope, so that we can get an immediate result when we're concerned about an individual. This will help us, as Dr. Thomas was mentioning, as we triage and track patients and keep monitoring and the clusters of infections.
Yeah. Break again. I want to talk more about testing and what happens when you get a positive or negative test back when we continue on this special edition of Newsmakers after this. We're back on this special edition of Newsmakers. Dr. Stephen Thomas, the test itself, what does it comprise of? What happens if my doctor says, yes, please go get a test for COVID-19? What is the test like?
So they'll take something called a nasopharyngeal swab. It's like a big Q-tip, and they'll put it in your nose, and they'll spin it around, and they'll try to get, if there's virus in your nasal passage or in your nasal pharynx, then they'll try to get some of that material. It gets put into some special, what we call media. It's just basically, it's liquid that allows it to be safely transported. And then once a day, we have a courier that goes to the Wadsworth lab in Albany, right? And then they run the tests, and then the test is looking for pieces of genetic material from the virus, is basically what it's looking for. And then they upload the data, and then our lab pulls down the results every single day. And that's kind of how the process works. Wadsworth, in my opinion, has been doing an incredible job of turning around test results. The volume that they're dealing with is probably just incredible.
How long does it take to get the test back?
Yeah, so initially it was about a day and a half. Then we got up to about 3 days, and now we're back to about 2 days.
Okay, that's pretty good. 48 hours?
I think it's pretty good.
And we're talking to a large number of counties as people watch us from Pennsylvania up to the Canadian, but a lot of counties. Is it uniform throughout the central New York region, or if I'm in Seneca County or Cuyahoga County, will my tests come back slower, or is everything kind of uniform now, or not yet?
No, it's not uniform at all. It all depends upon who your lab is, and it depends upon how that operation works. So you may use a commercial laboratory, and the testing, the site of actual testing could be in Virginia, it could be in Pittsburgh, it could be in California. So it all depends.
Well, but we're still getting them back in 48 hours, or maybe for some counties it's longer, depending on which lab they use and where they get tested. This might be for the book you write at some point later, Dr. Corona, but quickly, we should and do, we probably will do this differently next time as a nation, right? Where the testing might be more standardized and we do it more and more quickly. If it's this scattershot still, we probably need a better testing protocol.
Yeah, I think the vision would be to do what we call point-of-care testing. So right on the spot, you get tested and you know immediately whether or not you have the virus or not. Mm-hmm. That would be great. And then you can track contacts and use technology, which we're pretty excited about, which the South Koreans and people in Singapore did. It's a great way to triage and track patients.
But as you guys have said, right now you don't want everybody to be tested. You want the symptomatic people who the doctor says, I think you might have it. Those are the ones you want tested. You don't want anybody else coming into the hospital or those drive-up labs for testing, right? Just because they want to be
and that's largely because we don't have ample testing equipment and reagents now. If we could test everybody and we had unlimited reagents, that would be ideal.
Yeah.
But right now we want to limit it to people that are inpatient, that are really sick, or people that are sick on an outpatient basis, so that we can monitor and track their contacts.
Because if you were to do random testing, Dr. Thomas, and be able to do a random sample of the whole population, you could get an even better fix on where it is, right? But that's just not doable now, right?
Yeah, well, well, so I think there's kind of two phases. The first phase, which we are now pretty much done with, is do we have any transmission going on in our region? So people are coming in, they have symptoms, and we have a low threshold to test people. Just to define and to see, is the virus here? Is it being transmitted? Is it occurring in our community? After you kind of demonstrate that that is the case, then you kind of end up in the second phase, which is what Dr. Corona was just talking about, in that you test people who are sick, you test people who are sick enough to be in the hospital, you test your healthcare workers, because at that point you're in mitigation mode, where you're trying to protect the hospital workers, protect the patients, inform the health department of who's positive, who's not, try to conserve your personal protective equipment.
And that's the mode we're in now, definitely, mitigation, ever since the first case popped up.
Yes.
So what happens if I test positive? My test comes back positive, what am I supposed to do? What do I do? I'm sick, I've got it.
Right.
What happens? What am I told to do? I got to stay home, I got to self-quarantine?
That's correct.
Isolate myself in my bedroom, if I can.
You minimize your contact with others until you get the clearance from your physician.
14 days, longer, 14 days, will that do it if I'm sick? Do I get retested? The test comes back positive, I know I've got it. I isolate myself as best I can. I stay, even from my family. And then do I get retested to know I don't have it anymore? Or do I just assume I've resolved after 14 days?
Yeah. So it's an interesting question because there are different approaches to it. So one approach is test to ensure that you've been cured, right? And then the other approach is to not test and follow clinically and basically say, you know, once your symptoms have resolved and you do not have fever for 72 hours, for example, then you're good to go back to your life.
If I get it and it resolves that way and I'm not symptomatic, will I still be a carrier? Or have I done with it at that point?
Yeah, no, so that's a really good question because there's been there's been a couple of, I'll say, anecdotes out of Japan, for example, where someone was sick, they tested positive, they got better, they tested them again, and they were still positive. The issue is that the test, as I said before, they're testing for pieces of genetic material of the virus. They're not necessarily testing for a live infectious virus. So it's possible you could test positive, but not have live virus in you and not be infectious to other people.
Wow.
But that is still, I mean, it's a very, very good question, and we really don't have the answer to it yet.
Well, I've got other good questions that I know you've got the answers to, and we're going to pursue those in a minute or two when we come back here on Newsmakers. Welcome back to this special edition of Newsmakers. Dan Cummings with the CEO of Upstate University Hospital, Dr. Robert Corona, and the Chief of the Infectious Disease Division there, Dr. Stephen Thomas, talking about the coronavirus and this pandemic that we're all being affected by one way or another, even if we feel well. Talk to me a little bit about the antibodies that will show up, Dr. Corona, in a patient who has had. Can we test for those antibodies, and if we can, how might that help us?
So first of all, the body reacts to a virus by making antibodies, and there's certain subtypes of antibodies, but anyway, we can look for the different types of antibodies. So we don't have the test yet, but we're pretty close, and once we get the ability to detect whether somebody has antibodies, two things can happen. Right now we're taking antibodies from patients that have been positive and use them in a therapeutic way, so you can give the antibodies from somebody who was sick with COVID-19, extract those through plasmapheresis, through extracting the antibodies, and give them to sick patients and hopefully help them as a therapy. Is that working?
Do we have enough experience to know that works?
I think it's really early. I haven't seen a lot.
Yeah, okay. But it's promising. It might work.
But the other thing, the question about once you have the disease, how do you know you're okay? It would be comforting to know that you've had the disease, you've reacted to it, and now you have antibodies against it to protect yourself in the future.
Yes.
It's almost like a vaccine, but you're getting the real virus versus a vaccine, which is sometimes a weakened virus or a piece of the virus that's given to you.
So is that the case? So that if we do find antibodies after the fact, that we know we have protection going forward, or not necessarily?
So that would be the hope. So the hope would be you got infected, you survived, you did well, you now have what we would call durable immunity, meaning it will either prevent infection or prevent you from getting disease if you are infected, and the durable part being that it would last for a really long time.
Yes.
That would be the hope. We don't really know yet whether that's the case. We think it's very plausible, and it's if I had to bet on it, I would say it is the case. There have been some animal studies done where they have exposed animals, non-human primates. They've exposed them to the virus. And then a month later, they've tried to re-expose them, and the animals were resistant to re-exposure. So that's very comforting.
That's durable immunity. What's the difference between that and herd immunity? H-E-R-D.
Right.
Is that the same thing? Is it different?
No. So what I was speaking about was at the individual level, whereas herd immunity is at the population level.
How do we get herd immunity? Is that just that enough people that have durable immunity means the whole herd will get it? Will be better?
No, it's a numbers game.
Okay.
Right, it's a numbers game. So if we think about vaccination and we think about routine vaccines, when people are accepting routine vaccination, when you have a certain percentage of the population that gets vaccinated and develops an immune response to that vaccination, you now have a population level of immunity, which we call herd immunity.
Not to get ahead of ourselves, Dr. Corona, but it's really nice once in a while to look ahead of what we're in the middle of right now. do you see the day when, with this COVID-19, the coronavirus we're now fighting, when there will be general immunity? And so like next year, a year from now, will enough of the population have been infected and resolved so that we'll have this herd immunity, or are we going to need vaccinations? And will they be available? And how soon?
Well,
that's a bunch of questions.
yeah.
Feel free to answer any of them.
Yeah, we're excited about the possibility. I just saw a study or a group from Oxford that thought they might have the vaccine ready by the summer. You know, whether it could be commercialized and out and about is unclear. But the nice thing about vaccinations is, and we talk about herd immunity, not only are you helping yourself when you vaccinate yourself, but you're creating this herd immunity. So essentially, you're blocking the transmission from going on and on, as Dr. Thomas talked about. So I do think, I mean, I spent a few years in the biotech industry. I am excited about the different companies that are trying to develop vaccines or different ways to attack this virus. There's a company that's even injecting mice with the virus and grabbing their antibodies to use as a therapy. So I think we're going to see some exciting developments on the biotech front.
I think there would be people lining up for a vaccine as soon as it's available, right, Dr. Thomas? I mean,
I would hope so.
Well, you know,
but,
some of the we're not going to get into the anti-vaxxers, but those who have seen what this COVID-19 has done to the world and to this country, if it's a safe and effective vaccine, it would be very popular, right?
Yeah, I think that, you know, regardless of what the ultimate scope of this pandemic is and what percentage of the global population is infected, I still think we're going to need a vaccine solution, because there are still people who don't get infected. There are babies being born every day, right? So we're replenishing the number of people who will be susceptible. So I do think we're going to need a vaccine solution regardless of how this pandemic turns out and how what the level of herd immunity will be. We don't want to go through this again.
Yeah.
Right?
No, we don't. Yeah. And speaking of going through it, we've got another almost half hour with our guests. We're going to talk about what we're going through right now with COVID-19 here in central New York, and we'll have more for you in just a couple of minutes. We're back on this special edition of Newsmakers. Dr. Robert Corona, the CEO at Upstate University Hospital. Let me ask you about the readiness of the hospitals, yours and the others. You've got the beds available. You say at least Upstate's got maybe 77% additional capacity ready to go if and when needed. What about staffing, medical professionals and others to staff those beds?
Well, so far, our main goal is to keep our present staff healthy, because when they get sick, they can't help. We're okay right now with staffing, and we're trying to put together a plan in the event that we need more staffing. The governor's executive order has helped a lot, because it allows physician assistants, nurse practitioners to practice with a little bit more leeway than they had in the past. It allows physicians who are in good standing or other health professionals in other states to come into the state of New York, and even though they don't have a New York State license, they can help us in the state of New York. It allows foreign medical graduates who have a year of graduate training to come in and help practice medicine, where they would normally have to go through a more rigorous process to get licensed in the state of New York. So it's really helped us quite a bit in having the capacity. We haven't needed it yet, but we have the capacity for the surge. And with the 40,000 volunteers, I've gotten tons of commitments from retired physicians and nurses that they want to come back. So it's comforting, yeah.
Dr. Thomas, Dr. Stephen Thomas, the head of infectious disease, talk to me about PPEs, personal protective equipment, right? The masks, the gowns, the gloves. Do we have enough of those available at Upstate and other hospitals?
Right. So don't forget the face shield or the eye goggles.
Okay.
Yeah. So we do. So right now, again, it's like Dr. Corona was saying, and I'm not being evasive, but today we're good, right? So today we have what we need to protect our healthcare workers. Is there an endpoint in that supply? There is. Hopefully, I mean, we're working, we're trying to be very innovative in terms of how we're going to get resupplied with a lot of this PPE. And there's a lot of, we're getting a lot of outreach from the community.
Talk to me about that, because we've done the stories with people doing their best at their sewing machines and other companies reaching out saying we can retool our manufacturing line to cut and make masks or bandanas Is this all allowed in the clinical setting? In other words, is it sterile? Is it something you can use? These homemade, or are they just going to be there if they're absolutely necessary?
Yeah, it's more that if they're absolutely necessary. We had somebody offer today to make personalized masks for individuals that they could take home and wash themselves and so on. That might make them feel a little bit better about having some control. It's been fascinating. Dr. Thomas, myself, our president, Dr. Dewan, we're often on the phone in the middle of the night talking to people who have connections in China. It can get us PPE, but the prices are 10 times, 100 times what we would normally pay for them. It almost seemed like a scene out of the movie Argo that, we're trying to figure out ways to get PPE in the country.
It's kind of unfortunate, but the governor mentioned the same thing this week, Dr. Thomas, that states competing with each other and vendors bidding up the prices. I mean, that's sickening, really, but I guess everybody's got to make a buck. PPE, the shields, the eyewear, the masks, the gloves, the gowns, how much of it is reusable and how much of it is single use only? Can they be cleaned and reused?
Right. So in a non-COVID world, it's usually a one and done sort of scenario. In a COVID world where PPE is not a limitless resource, then we are looking at ways, and there's guidance out there about what can be reused, under what conditions it can be reused. There are ways to actually increase the safety margin of reuse in terms of methods of decontamination, for example, of masks or face shields. And so all of those things are on the table. All of those things are on the table.
I promised this one gentleman I'd ask, because he's asked me twice, if it came to that, the need for breathing apparatus, CPAP machines that some people use for sleep apnea.
Right.
They don't need them anymore. Maybe they're used machines, they're older, but they're clean. Are they of any use in this setting for patients that are sick in bed with COVID-19? Or is that like a last resort too?
Yeah, so there's actually some, so it depends on how you look at it. I mean, they are, again, there's a lot of innovation going on right now, sort of in the biomedical engineering space, to look at, okay, it's a CPAP machine. What are the components of that CPAP machine? So you have a face mask, right? That face mask can be detached and potentially be made into a mask that somebody could wear. It has motors, there's a motor in it. There's ways to, we were hearing this morning about ways to decontaminate your CPAP machine. Could those be used to decontaminate the masks that, the N95 mask, for example? In terms of that machine actually being used to support somebody's breathing who has a severe COVID infection, I think the answer to that is no. Okay. And there's been experience, at least in, there's communications from China that was really not viable. Yeah.
All right, we're going to talk more about COVID-19, how bad this could get, and what we all need to be doing right now, those of us that are healthy and well, for ourselves and our families, when we come back. We're back on this special edition of Newsmakers. Dr. Robert Corona is the CEO of Upstate University Hospital in Syracuse. One more thing that might help out on the ventilator demand. You've talked about a mechanical possible option here. Tell us about that.
Yeah, so our intensive care unit doctors, we're talking this morning at what we call our incident command, which meets twice a day, about taking the manual ventilators that you've seen where you ventilate people with, people actually pumping the ventilator, and putting some kind of mechanical apparatus on it to push that. So that will expand our capacity of having ventilators. It's not optimal, but as we've been mentioning, it's managing through kind of like Apollo 13. You figure out what you got and you make it work. Yeah,
because we do have a problem, Houston. Dr. Thomas, before we get to managing the fear, let me talk to you about how bad it could yet get here in central New York. Everybody looks downstate, and every day we hear the governor. Obviously, New York City and downstate has a big problem.
Yes, they do.
Could it get that bad here? I mean, our population density is not nearly what it is down there. That's a huge problem.
Right.
But we are seeing our curve go up as well, in Onondaga County particularly, and the other counties. And the governor says we might be 14 to 21 days out from the peak, which, is that encouraging or discouraging, and how bad could the peak get with illness and death?
So, I mean, if we look at what happens in the state in terms of influenza every season, there does seem to be a pattern where downstate we see the outbreaks occurring of influenza, and then it moves to Buffalo, and then Syracuse starts to have its peak transmission. So if it follows the same sort of pattern, then we will be a couple of weeks behind New York City. That being said, because of how this is transmitted, again, sustained close contact is the most common. The population density down there is a little bit different than the population density up here. We, just by the nature of how we live up here and our land and the distance that we have between neighbors and whatnot, we're a little more socially distant at baseline than you are, in New York City. But that being said, we have 700,000-ish people in this area, and if the attack rate, meaning the percent of people who are going to get infected, is 50%, you have 350,000 people getting infected, and then you can do the math of how many people are going to get sick and how many people are going to need to come into the hospital. That's a much different scenario than we are used to normally in terms of the hospitals in the area and the number of patients on a daily basis. And you think about those curves that I've seen on the station before of do nothing and you get the big peak and you very quickly exceed your healthcare capacity, and a lot of bad things are going to happen. Versus we all do the right thing, which we're going to talk about later, I know, and you flatten that curve and you stay within the capabilities of the hospital. We'll see.
Well, let's talk about that right now. Social distancing, Dr. Corona. Everybody's been told to stay home. Most people have been put out of work. The schools have been closed. The colleges have been closed. How is it working? And why is it so essential that we stay distant and within our homes?
Well, I think it's working. There are some positive signs that there's been a little bit of a modification in the rate of hospitalization. As Dr. Thomas mentioned, that 6-foot distance, it allows gravity to kind of drop the droplets down so that you're not going to be exposed. It's just so important, if surfaces are contaminated, to wash your hands, to be conscientious in your own homes about bathrooms and surfaces and who's using what drinking utensils and eating utensils. So I think it makes a big difference, and we've seen it in other countries that it's worked. So I think it's working here.
But needs to keep working for Dr. Thomas some weeks to come, right? There's no reason to be skittish about this. We're in this for a long haul.
Oh, yeah, I mean, no question. The analogy would be we're still practicing for the game, right? The game has not really started here yet. It's very much on down in New York City, but again, we're a couple weeks behind that. That's my personal opinion. So we need to do better. And like Dr. Corona was saying, the experience in China, the experience in South Korea, the experience in Singapore, in places that put aggressive social distancing policies in place, and in places where people took them seriously and they actually did what they were supposed to do, it was very clear that it made a difference in transmission, and it was very clear that it spared people infection, and it spared, of course, people dying. And in those places, they were able to resume some sort of normalcy in a reasonable time frame. I talked to a buddy of mine who's a physician in Singapore, and they're still having cases there. But because they acted so early, they're very much in a comfort zone of being able to see those patients, take care of those patients, take care of the non-COVID patients, and still have some kind of normalcy within their society.
It's manageable now.
It's manageable. It really is. It really is one of those things where, pandemic response. It is a team sport, and every single person, whether you're a healthcare provider or a non-healthcare provider, Onondaga citizen, you play a role in trying to tamper this down.
We're going to come back and talk more about what we can do, what we should do, and how patient we need to be as we manage our own anxieties and fears when we come back. We're back for our final segment on this special edition of Newsmakers. Dan Cummings with Dr. Stephen Thomas and Dr. Robert Corona from Upstate Medical University. This is scary, Dr. Thomas. You're an infectious disease expert and you study these things, and now we're all living this. It's important as we realize how significant it is, how threatening it is, and how deadly it can be, that we still manage our fears somehow. What's your best advice to people who are at home watching this, healthy for the moment?
Right. I would echo what Dr. Fauci and Dr. Birx have been saying at the federal level, which is, when in doubt, look at the facts, right? Look at what we know. And when we don't have a known, fill the gap with what we know from other experiences. So we know we know it's a virus. We know how it's transmitted. We know a lot about what the symptoms look like. We know how to test people, and we know that how to protect ourselves. We know that good respiratory hygiene, good hand hygiene, and social distancing will help the problem. So that's what I would advise people.
And yet we got to be patient too, don't we, Dr. Corona? Because we've only been in this for a few weeks, really, in central New York, and we're in it for some weeks or months to come. So the mental health issue, the emotional aspect of being cooped up and anxious at the same time can wear on one.
It really can. And fear, I often will have this conversation with my family. Fear can hijack the brain, right? And then you do things that you wouldn't normally do. You tend to cling on to things, your beliefs. You tend to not listen to the nuances of the message, and sometimes you get so much messaging, it's confusing, you can't keep all the facts straight. So the best way, as Dr. Thomas mentioned too, practice the social distancing, do the good hand washing, the good hygiene, but also try to exercise, try to eat well. Those things keep your constitution or your body in good defense mode, and that's going to help you get through and do something positive for somebody else.
Yeah, get your rest and reach out to others. I don't want to look back in this program. There'll be plenty of time when this is all over to do a postmortem and the books that'll be written about this. But looking forward, Governor Cuomo, Dr. Thomas, has mentioned a couple of times this week that there might need to be in the future a refined strategy. He started to almost second guess, well, should we have closed all the schools and closed all, because now you're sending all those young people home from college and schools into the houses with older. So he says, we're not sure. It almost sounds like for the next time around, if there is, God forbid,
right,
that we might do that differently as a society. Is it too early to even talk about that? Because the schools are certainly going to stay closed for the rest of this semester into the summer. What do you think about that?
Yeah, no, I don't think it is too early to talk about it because I'm not sure that we're going to have COVID-19, COVID 2020, 2021, and then that's going to be it. It is possible that SARS-CoV-1 it disappeared, from the planet apparently, or maybe it's probably still in animal populations. But MERS is still around. There is still consistent transmission occurring in the Middle East. Lower numbers, of course, but there's always the potential that it could break out. I think your question is an interesting one because if you look at Ebola, we learned a lot of lessons from Ebola, and then we had MERS-CoV, and we relearned a bunch of lessons with MERS-CoV, and then we relearned a bunch of lessons with Zika. So when you say, is it too early to think about learning lessons? I say, well, we've been learning a lot of the same lessons over and over again, and I think I do think that it's, not to editorialize too much, but I do think that it's time to look at some of the basic fundamental concepts of biopreparedness, both as a nation and globally, and what are those fundamental aspects that we are ignoring, or that we are not being consistent in our approach to. Because, I agree with what the governor says. The answer to that could be, it's not going to be a respiratory virus next time. Next time it could be something completely different. So, there are some very fundamental things that we could be doing to be better prepared to respond to whatever, I guess this probably meets criteria for disease X, disease Y, whatever the next pandemic or major epidemic is going to be.
Dr. Corona, from your point of view, is the healthcare system ready to do what Dr. Thomas suggests? Do you think and get ahead of the curve the next time? Things that we can have already learned from this that we'll put into practice?
I think there's a lot of lessons learned in this event, and I think we need to start to think about investing in public health, investing in frontline care and being prepared for almost any kind of pandemic or situation where we're going to have a lot of people infected by something or involving some kind of mass disease state. And I think our hospitals have been largely looking at acute care, and we have to start being more prepared for, I think, preventive care.
Right. Well, thanks to you gentlemen, we are in a position to have great information going out from not only this TV station, but market-wide here in central New York. So Dr. Robert Corona, the CEO of Upstate University Hospital in Syracuse, and Dr. Stephen Thomas, Director of the Infectious Disease Division at Upstate. I want to thank you on behalf of myself and this TV station for everything you've done, not only to fight this thing on the front lines, but also to be continually available for the public information, because the facts are what are very important. So we're grateful. We're also grateful to all of you for tuning in. And if you're just joining this program late, we have posted it online and it'll be up for several days, bearing in mind that Drs. Corona, Thomas, and myself have had this discussion at between 1:30 and 2:30 on Thursday, March 26th. If you're watching it, there certainly have been developments. The most important thing is take care of each other, take care of yourself, and stay healthy. We'll see you soon.